Hey, well, thank you for having me. Are people able to hear me okay? Okay. So I'm going to do something a little bit different in my talk. I'm going to talk about a grant submission that we pulled together in November, along with several people in this room. This was a P60 Center grant through NIH. And the goal of a center grant is to bring people together around a particular topical area. And for us, this was the integration of alcohol science, alcohol research, and AI. And so what I'm going to do is talk a little bit about some of the projects that we propose to do, because I think they offer a really nice illustration of the way that AI might be integrated into something mental health focused like alcohol. And I'm also going to talk a little bit about the process, because one of the big things about doing interdisciplinary work is that sometimes people don't know where to start. So I'm going to talk a little bit about how do we get this collaboration going. And I'll begin by just acknowledging the team, all of the people who came together, and a point that I wanted to make to start out with, and that I'll make throughout the talk, is that this was very much an interdisciplinary effort. And I think that AI really lent itself very well to ways in which we could cross disciplines, cross methods, and really make the most of the data that we were able to collect to address some of these public health problems. I also wanted to acknowledge my co-principal investigator, Craig Calder, who's also in the room. He and I were leading this team of really fantastic scientists. So the goal here again, I think I might just use this. The goal here again was to bring scientists, AI scientists, and alcohol scientists together to develop this center. We call our center the Center for Alcohol and Artificial Intelligence Research, or CARE, through this P60 Center grant. So I'll start by telling you a little bit about the scope of the problem. Alcohol use disorder, or harmful alcohol use, is one of the most common of the mental health disorders in the United States. About a third of people in the US will meet diagnostic criteria for alcohol use disorder at some point in their lifetimes. And many more people drink in ways that are harmful or hazardous to themselves or other people, even if their drinking falls below clinical diagnostic thresholds. Harmful alcohol use has been rising, especially in particular groups, including women, older adults, and members of racial and ethnic minority categories, as well as individuals who might be categorized as lower SES. And so the burden of alcohol use disorder is disproportionately falling to some people within the United States. And that's important when we talk about how AI might be used to address this problem. Alcohol misuse is also carries a heavy financial burden in the United States to the tune of nearly $250 billion every year. And importantly, only a small percentage of people who engage in harmful alcohol use are identified ever as having a problem or needing treatment, or receiving treatment for those even who do identify themselves as having a challenge. And this is for a variety of reasons, including structural and institutional barriers that prevent meaningful progress. And so therefore, especially people who are racial or ethnic minorities are disproportionately left out of both identification of harmful alcohol use as well as treatment. And so the scope of alcohol use disorder in the United States is really quite broad and quite burdensome. And we really are at a juncture of needing new methods and new approaches, not just to be effective, but also to reach a broader swatch of the population and to have a broader impact of the science that we're doing. So as many of you in the room probably know, a major advantage of AI is that it can be used to analyze enormous amounts of data, to detect patterns, to make predictions, and to solve problems. And AI can do this much, much faster and much more accurately and on a greater scale than humans can do. And the status of the field currently, and you can see some of this as we talk about our data, is that we are increasingly using methods that yield a lot of data. And it really is too much for human scientists to be able to use effectively on their own. And so AI can be applied to harmful alcohol use to integrate these large data sets in the service of identifying and classifying and intervening on harmful alcohol consumption. And this could include a variety of different ways. So AI can be used to identify harmful patterns of alcohol use at the population level, It can be used to streamline the identification and disposition of people who have alcohol problems through medical records or detection of frequency of medical visits. AI can be used in large-scale data analysis to evaluate our policies effective, using large national or even international data sets. And then AI also can be used for intervention. So we can do things, some of which have already been talked about, like tracking people. Increasingly, people are using tracking devices as they're moving around. I'll talk about a project that uses this today. Our phones are tracking devices. All of these things, our smartwatches, can be used in the service of both tracking and also intervention. And then, of course, things like chatbots, where people are wanting to know, hey, is my alcohol use a problem? AI can be used to help people make decisions for their own health and their own treatment seeking. Okay. Unfortunately, though, people in addiction science, the field of addiction science, has been somewhat slow to adopt AI, partly probably for reasons having to do with just not really knowing where to start. And so the center grant that we proposed is supposed to provide a forum where people can begin to take their alcohol science ideas, put them in, pair them with artificial intelligence professionals, and see those ideas come to life through AI. So the center that we proposed will take place if it gets funded here at UB. And we argued, and I really believe that this is a great place to do this work. We have over 150 people here at UB alone who are doing alcohol research. UB, whether you are aware of it or not, I don't know, has a national reputation for excellence in alcohol and addiction science. And there has been tremendous investment both in Buffalo and in New York in AI initiatives. And so this seemed like the exact time and the exact place to be doing this kind of center. And you got a little bit of a glimpse of this when Lauren presented her data, but a center also has multiple components. So it has an administration core, which sets up, how the work is going to get done. It has a resource core, and for us, the resource here that we're offering as part of the center is AI. It has a dissemination core, which ensures that the science is going to get out to the public. In our proposal, we wanted to use community members and stakeholders to figure really prominently in this dissemination so that there was a feedback loop. So we just are disseminating our science, but we're also using stakeholders to understand what science do they want and need, what is going to be helpful to them in understanding about how alcohol and AI might be integrated for the public good. And then there are these 3 research cores. And so those are the things that I'm going to be talking to you about today. These are specific research projects. Each of them is focused on the integration of alcohol, science, and AI. And then finally, there was a pilot projects core, and the pilot projects core are small, as you can imagine, small-scale pilot projects that are really investing in mostly junior scientists or early ideas, seedling ideas that are partnering alcohol and AI to really sort of energize the field and move investigators forward. So a little bit about the process. How many of you do interdisciplinary work now where you're crossing with other disciplines? Just like show of hands. A few of you. Okay. Okay, interdisciplinary work always sounds really great, and then yet it's sometimes hard to do because we're speaking different languages and we're not really sure where to start. So before I talk about the individual projects, I'm going to say just a little bit about how did we come to this. So again, here's our team. I have, this is actually even a portion of our team, but I have people separated out. So we had these alcohol science people, we had these AI expert people, we actually had a larger group of them than is represented here, but here are the 2 main people. And then we also were working with the VPRED's office with a really fantastic team that helped us develop this proposal. So there was an RFA put out, a call for proposals, saying, hey, NIAAA wants to fund a center. Those of us who are alcohol scientists get together often when NIAAA puts out a call and says, do we want to put in a proposal? Because there's so much strength in alcohol and addiction studies here at UB, many of us already had been thinking, we want to do something that brings people together, addiction scientists together. And so we had a series of meetings and we were talking about different ideas. And then one that we kept coming back to was this idea of maybe integrating alcohol science with AI. But none of us really knew anything about AI, and we didn't even know who to reach out to about AI, which seems kind of ridiculous because we just talked about how much investment there's been in AI. But we were in the psychology department. We weren't sure who to reach out to. Somebody knew Kenny Joseph and said, I think he does something with AI. Maybe we'll reach out to him. And so it was really that informal. And so we initially had an idea, our own sort of project ideas that had nothing to do with AI. And we scheduled this first meeting with Dr. Joseph and talked a little bit about, this is what I'm doing. These are the data sets that I have. These are the kinds of questions that I'm interested in answering. None of them had anything to do with AI. We weren't sure that they could. But even in that sort of spitballing kind of meeting, Dr. Joseph was saying, yeah, you could do this kind of thing. You could do that kind of thing. We took lots of notes. And then we went back and talked with our own investigative team and thought more about some of these ideas. Chose one or two maybe to develop further. And that by now we're thinking like, well, here's how AI might be integrated into these ideas. And then we came back and we had a second round of meetings, again with Dr. Joseph, refining the AI piece of it and how that might work at a very sort of gross level, not in terms of details, but what might this look like if we partnered our content addictions idea around alcohol and used AI tools to magnify it or enhance it. So we had the second round, we refined, and then we went back and we started to build our teams. And in those teams, this was like, who do we need to have the content expertise to do these projects? And then step 5 here was this AI team building. And at this point, we began to reach out through Dr. Joseph's suggestions to specific people with AI expertise across the campus, many of whom were part of the Center for Data Science here, some who were separate, but people around UB who would have this kinds of expertise. And so from this, we developed 3 teams of researchers. And on each team, there was both the alcohol science representation. Oftentimes, there was somebody from another discipline. So you can see up here, we had people from communication. We had people from geography. We had a number of different people. But every single team had somebody who was bringing AI expertise. Oftentimes, that person was the co-PI for that particular project. And so then those teams began to meet separately and kind of develop the project further with the expertise that they needed. And so then we're kind of off and running with our AI and alcohol science ideas. And I'm going to spend the rest of the time talking to you about some of these. But I did think it was important just to say, this is how this happened for us. And I think it was really effective. It started with somebody just coming with this kind of expertise and saying, here's how I think you could use some AI tools. Us reflecting on that, taking it back to our own research teams, talking more about how could we apply this. And it was very iterative and it was very collaborative. So you can see up here where we landed with our teams and some teeny tiny pictures. And here are 3 projects. And so the 3 projects I describe are all 3 instantiations of the ways in which AI can be partnered with alcohol science, and that I think really, to me, highlight the promise of this kind of marriage to advance the field, to advance this particular field within mental health, which is alcohol and addiction studies. So the first of these projects, the lead investigator is Craig Calder, and then you can see here he also has a co-PI who was bringing AI knowledge, Ifoma, and he had not worked together before, so this was an early partnership that was formulated around this particular center. And the challenge here is that we know that parents are an early and important source of socializing kids around just about every kind of behavior, and they are an early and important source of socializing kids around alcohol. So some of the first things that we learn about drinking and drugs, we learn from watching our parents and listening to our parents. There's a lot about parental communication. You don't have to be around very long before you see an advertisement somewhere that says, hey, talk to your teen, talk to your kids about alcohol. But one of the things that has become clear is that not all parent communication around alcohol is good. And some of it may actually enhance risk for teenagers. And so, of course, for people who are parents and probably also for teenagers, you want to know, so what is it about a conversation about alcohol that's going to be helpful and what is it that's going to be hurtful? And so the goal of this particular project was to apply machine learning to understand the nature of parent-child interactions and to understand parent-child interactions specifically around alcohol use, to understand what is helpful and what is harmful. So the aims of this particular project are to use an observational coding system, which is the continuous assessment of interpersonal dynamics, or CADE, to code parent-child interactions. And in particular, there's an interest around not just the content of what's being said, but also about the tone and tenor of what's being said. So some of the coding is around, was there warmth? Does there seem to be an assertion of dominance or power struggle in this conversation? Now, CADE is not a new process, but usually CADE coding is done by humans. And so humans are, the data are being coded, and then humans are trying to analyze it. Humans are trying to make sense of these patterns. And this yields an enormous amount of data. It is incredibly labor-intensive, time-intensive, hard to do. So the goal here of this project is to develop a machine learning algorithm that is using multimodal input. So this includes things like language content, facial expression, prosody, all of the different aspects of a conversation that go beyond simply just what is said, to automate the coding of these videos. And then to train this algorithm on a set of pilot dyads. So this is a parent and a child. And then to validate it on a new sample of dyads. So the other idea is to compute these summary scores from the ML algorithm to compare these dynamics across different groups. So are dynamics the same, and are they similarly effective in female and male caregivers? Are they the same across different racial or ethnic groups? This would be important in terms of the kinds of direction that we give. And then the final piece of this project is to use these summary scores to predict adolescent alcohol outcomes. So do these conversations actually make a difference in terms of behavior? So this is, I think, a really exciting project. It's one way that, that machine learning and AI techniques can be applied to something that can be done by humans, but not very efficiently. And this allows for a much richer, much more enhanced way of understanding this. And so you have from this project, of course, the actual outcomes, which is new information we'll have about parent-child interactions around alcohol. But we also can then take these machine learning models and apply them to other kinds of dyadic interactions that are important in determining health and mental health behavior. Okay, so another project that is part of this center grant is acute alcohol tolerance and drinking rest. So this is a really different kind of project, also really important. This focuses on the idea of acute tolerance, and what we know from laboratory studies is that one of the biggest public health problems about alcohol is people engage in dangerous behavior. They drive, they may operate machinery, they may engage in parenting tasks, they may engage in interactions with other people that result in violence. Why do people do this? Well, one theory is that this is due to a mismatch between how intoxicated people perceive themselves to be and how intoxicated they actually are. It may or may not surprise you to know that people are not always very good at gauging how intoxicated they are and tend to think that they're more sober than they are. So this is known as acute tolerance, and it is essentially the gap between where you are, how drunk you are, and how drunk you think you are. And in that gap is sort of a danger zone and also a potential point for intervention, where you could say to people, here's how I can help you gauge your tolerance a little bit better so you can make better decisions about what you can or cannot do, or should not do. Okay, so this process has been almost entirely modeled in the lab. So there's a lot of laboratory experiments that evoke, dose people on alcohols of BACs up to 0.08 so that they're mildly intoxicated, and then identifying that people, are not able to really gauge how drunk they are. But there's been almost no naturalistic study of this in the environment, which is really, of course, important to do. So the goal here is to use AI of this project to identify this mismatch through an examination of acute tolerance in daily life using ecological momentary assessment, or this EMA method, taking people out in daily life, having them report on their behaviors, monitoring their behaviors, and also using measures of BAC, blood alcohol level. And so using these modeling techniques to pull together large amounts of both laboratory and naturalistic data to develop a model of this acute tolerance, and then to use that model to predict risk-taking in real-world circumstances. So this is the second project. You can see it's very different from the first project, but it's a really different application of these methods to answer questions that people have been trying to answer about alcohol and the harmful alcohol use, but to do it in a much more efficient, much bigger, much broader way using AI. Okay, the third project is a project that I'm the PI on along with Rachel. And I'm going to spend a few more minutes talking about it because it's very dense and also my project. So the challenge of this project is we know that emotion is a really important driver of drinking behavior. Both positive and negative emotion drives a lot of human drinking behavior. Negative emotion seems to play a particularly important role in harmful alcohol use. And people's moods fluctuate a great deal throughout the day. This is particularly important for people who engage in harmful patterns of alcohol use. The other thing that we know is that alcohol cues also are important drivers of drinking. So when people see things that remind them of drinking, they're more likely to want to drink or have an urge to drink. This has been demonstrated over and over again in the lab. But we also know that these kinds of cues you can be found in daily life environments everywhere. We're driving past liquor stores, we're driving past advertisements for a particular kind of alcohol. Something pops up on your phone for a particular kind of drink that looks really great. But most of the alcohol cue literature has been conducted in a research lab. There has been very little attention paid to alcohol cues in daily life environments. And the kinds of cues that have been studied are people reporting on, yes, I saw this, yes, this was a cue, yes, it was triggering to me. But because we now all are carrying smartphones around, which are GPS enabled, we now can begin to see something new about alcohol cues, which is how do people travel in space, geospatially, and how might we be able to detect cue exposure through that human activity. So for example, we can certainly see, was somebody exposed to an alcohol outlet? Was somebody near a bar? We can also say, was this person someplace where there was a lot of alcohol outlet density? There's lots of places they could drink. Are they spending a lot of time in or transitioning into and out of those kinds of environments? So we can begin to think about alcohol cues and cue exposure in a very different way using geospatial information. And this information, of course, could be combined about daily changes in mood. We know that people are going to be more vulnerable to alcohol cues when they're in a negative mood state. We can learn more about how might we intervene on that if we know more about the processes by which people encounter these cues in daily life. So this project, this third project, is to apply large data modeling to develop and test predictive models of drinking risk in daily life as they occur in response to negative emotion and these environmental drinking cues. So this project has 3 stages, and the first stage and 2 different data sets. So one is an existing data set from a developmental R21 grant that we had from NIAAA that we're just finishing up. And the second data set will be newly collected data set. And so with each of these large modeling approaches, we'll first develop the model, and then we will test it on a new data set. So that's the plan. The data set that we have and the one that we will collect both use 14 days of continuous GPS monitoring, and I'll tell you a little bit more about the approach there in just a second, and multiple daily EMA reports with people reporting on their emotion, where they are, drinking locations, mood, how much they are feeling like they want to have a drink. And so we'll train and validate these probabilistic models. First, we'll start with, I'll tell you more about that in just a second. And then the third phase, the final phase, is to take these models that predict drinking risk and to apply them in like a little trial of a feedback intervention to see how do people respond when they're able to get information in their daily lives as their risk is changing as they move about their day. So this 14-day assessment that we have used and that we would use again in our models, again, people come into the lab, We do a very detailed interview with them about their drinking. We ask them, what are the places that you usually drink? We're taking detailed information about this because we're eventually going to pair that with the geocoded data that we're collecting over the 14 days. We're also orienting them to the EMA process. They take a phone out with them, and the phone has an app on it that then prompts them multiple times a day. So they're asked, if you're feeling strong emotion, strong negative or strong positive emotion, we'd like you to begin one of these self-report surveys to tell us a little bit about how you're feeling, how much you want to drink, a little bit about where you are. We also have time prompted. So if somebody's gone 4 or 5 hours and they haven't filled out a survey that they've prompted themselves, they'll get a little ping saying, hey, could you complete a survey? And then they're being monitored on GPS continuously, and then we match the geocoded information to their daily EMA information, to that baseline information that we gathered about where do they typically drink, what are your favorite drinking locations, and we have a very rich depiction of this person's ecological drinking environment that we can now tell a lot more about, where are they and where are the individualized triggers for them each day. So here's the AI part. We are first going to be using random forest analysis, and this helps to tell us, prioritize what are the variables that are most important. And then second, we use a Bayesian network structure to depict the variables that are most strongly related to drinking risk. So there's 2 sets of analyses that we're doing that are getting proximally closer and closer to a very personalized predictive model of somebody's drinking risk in daily life. And then that last stage, we're going to take the model, especially that we had derived from the second set of models, and we're going to use that to make highly personalized inferences about that person's drinking risk. And then we will give them some information about, as they're going about their day, here's where you're at risk. You might want to do something like you may want to take a few deep breaths. You may want to draw on a coping strategy. You may want to get out of that, dense bar area. And we're going to see how did they respond to that information? Does it influence their drinking? And this is a proof of concept. It's not a clinical trial. It's just to show we think we can do this, and then if we do this, how do people respond to the information? And then, of course, next steps would be to scale that up, assuming the preliminary data suggests that that's the next course. So 3 different projects, very different in terms of what they're getting at, but all helping to address different aspects of the problem of alcohol, harmful alcohol consumption, and the various ways that that manifests. And all of them are using AI in different ways that help, move the field forward. So, so from some conclusions from this, AI is powerful and underutilized, at least in the field of alcohol science, for a number of mental health problems, including harmful alcohol use. And there are multiple applications of AI that can be used to address these harmful public health problems. What I think is really exciting, and what I was very excited about as we were writing this grant, is that these applications can cut across multiple disciplines, multiple methodologies. As people are collaborating more and doing bigger and bigger science, we have more and more diffuse and rich data, and AI is really well suited to this. We have the project that I mentioned earlier, the R21. We are in the process of developing and analyzing that, not with AI, and it is massive. It's overwhelming how much data we have, and trying to sort our way through it. And what we're mostly doing is reducing the data and reducing the data and reducing the data just so we can analyze it, and leaving a lot of information out just simply because there's nothing else we can do other than try to simplify it. So AI has the potential to get around some of those challenges and to really make better use of some of the data that we now have available through these various data collection methods. I did also want to make the point that many of these applications were not things that investigators thought of themselves, that we ever would have thought of ourselves. It was only when we met with people who had this expertise that we could begin to think about, the kinds of questions we could answer that really pushed us a little bit farther in our thinking about the research that we were doing. And I think that was, I think for me, the most exciting part of this. And the process was very collaborative and iterative, and I think resulted in something far better than if we had to try to do any of these things on our own and not worked in a cross-disciplinary way. The other thing is at that early stage, I mentioned, most of us had several different ideas and thoughts that we could do with the data. And so, I showed you the three projects that we focused on, but there were easily like 9 or 10 out there that we could develop. And so I think that, this brainstorming process really can generate a lot more, a lot of richness in terms of next steps that we might take. The other thing is that as we have broader reach and are using bigger and bigger methods, we have stronger representation. I think that a lot of this can also be of benefit to addressing some of the health disparities that I talked about at the beginning of the talk. And also, using AI methods to get to people who are in the midst of their daily lives, moving away from traditional models of intervention that require people to come into a clinic for treatment, require people to, seek out a therapist, to have the money and the time to be able to do those things. These approaches help us move beyond that. It is the case, though, and there's data suggesting that members of historically marginalized groups may be suspicious of big data approaches. And so in our center, we do have plans to work with community stakeholders to see how can these methods be developed in ways that are going to be palatable and easily accessible. And so the focus there is on responsible AI that can be used well by larger groups of people, and that is going to be more applicable. Okay, I think that's the end, and I can stop here, and thank you for listening. I can take any questions you might have.
So my question is, how are you trying to ingest that psychological data, right? Like you try to give some, like you try to give something to the stimuli and try to see how it's responding, and how do you convert that into a like a structure to
Without AI or with AI?
with the
So so the question is, how are we going to ingest the structure of the data? Is that what you're asking?
how are you getting that data, right? Like you are trying to give something to the stimuli and try to see how he like reacts to the stuff, and then we try to make data out of that and try to model it out. So that
So, well, what we have now and what we will have even more of are multiple daily reports over nearly 200 people of, at 5 times a day over 14 days. How are you feeling right now? Are you like feeling like you want to drink? Are you drinking? And we also have geospatial information about like where were you? So were you, when you were having these feelings, were you in an alcohol dense kind of place where there's lots of alcohol outlets, it'd be easy for you to drink? Were you in a place that we can see from the geocoding and that we have identified in that baseline interview is one of your favorite drinking locations? And so this is going to give us a lot of information about the ecology of a person's drinking risk as they're going about their daily life, and how much, where they are, how close they are to alcohol, cues like alcohol outlets, bars, restaurants, places where they might drink, and their mood, putting all of those pieces of data together that we have, and generating from the models that I described, the random forest models and the Bayesian network models, predictive models that tell you with all of this information, we know what are the most important variables in terms of predicting risk, and how are they associated with drinking risk. Does that make sense?
So my question is a little bit long and tangentially related. So I guess my thought process is that since humans are not exactly aware of how intoxicated they might be, is that something that can extend to emotions as well? Things like anger or stress. So humans broadly unaware of how they feel, and if so, can AI intervene with helping them gauge where they are? Because my smartwatch can tell me if I'm stressed, but exactly how much do you think there can be an intervention with that?
Yeah, I think that's a great question, and I think it speaks to Lauren's data and probably Kristen's data, that as we begin to, so far psychology has relied, and most human research has relied on people telling you, yes, I feel sad, yes, I feel stressed, yes, I feel happy. And people are okay about knowing that, but there's also a lot that's happening with people that they may or may not be aware of or able to report on for a variety of reasons. And so as we move to physiological indicators of drinking risk and things like biosensors where we know, like, did they actually drink? I have not done much of this, but there are physiological responses when people are exposed to cues that suggest that they are wanting to drink or preparing to drink. So we can begin to access other ways that beyond somebody just telling you or being aware of it themselves, that they are at risk for drinking because perhaps they're physiologically shifting. It sounds like the technology is not there yet, but I think maybe what we're moving toward is that we would be wearing things that would be attuned to these things even before we know them ourselves, and people could get feedback in order to avert harmful outcomes.
Thanks for the talk. It's very nice. We have a lot. Oh, no, I'm not. I have a question. Give me if you want to. We have a lot of students in the audience that are going to be leading their programs and working on interdisciplinary teams. And I really appreciate the way you brought in some of the challenges. So, from that point of view, do you have any words of wisdom or things to reflect on your experience?
Yeah, so I asked people to raise their hands, and I saw only maybe about a tenth of people saying that they've done interdisciplinary work. And I don't know if people, maybe I'll just say, like, what do you think are some of the barriers to interdisciplinary work?
Knowledge barrier.
Knowledge barrier? Communication? So knowledge, communication, anything else?
Being able to find the resources that actually help you.
Okay, resources. Yeah, so and knowledge communication resources, of those, I think maybe the biggest barrier is, so like, you don't have the knowledge, right? And so that's why you're working across disciplines. Sometimes you don't even know that those options are there. So that, I think, is why this kind of event today, that's getting people to think about how can what you're doing be applicable to other disciplines, who's doing this work, is really important. But communication is a really big one. And I think being able to communicate, and I can say, actually working with Rachel on this project, and a lot of this was like, I kind of see what I'm trying to do, and she was like, I see what you're trying to do, and we had several meetings, and a couple, for me at least, where we're like, okay, like I see what you're trying to do, and then translating that. But I think it takes some patience and some listening, and really stepping outside of the lingos of our disciplines, and thinking about talking in a day-to-day kind of way about what can I do here, what am I trying to do here, and meeting at those junctures. And then you can kind of scale back out to get fancy with your technology and what you can do. But the communication piece, I think, is really big. And the further we get in our disciplines, I think the more socialized we get to really only be able to talk about our work with other people who do our work. And that's not a good thing. It's now that I have this microphone, it's not a good thing for academia either. Like, we need to be able to get so that we can talk to people about why what we're doing is important. If we just are talking in ways that seem really kind of highfalutin and nonsensical and unimportant, that, I think, is contributing to some of the problems that we're facing at the national level. Sorry to get on my soapbox.
Hi, thanks for the presentation. I'd like to ask about biomarker, specifically beats per minute. As we know, there's a correlation between beats per minute and alcohol use. Has that been thought of as phase 4 or 3 or 5 for you? Because we're seeing that as you use alcohol, beats per minute is reflected on the on rise. So I just would like to know, because everyone's wearing smartwatches and has access to this, and that would be basically maybe a nudge or a push or a shove to say, wow, I got my beats per minute have exceeded. It's time for me to. So basically, a psychological and a physical nudge.
Yeah, and that is not my area of expertise, but we actually have another exploratory R21 grant that was on the bubble, and we just resubmitted it. But it's to look at some of these more physiological processes around emotion and emotion regulation, and from what I understand, there's still some imprecision in that. But I think as we move toward more and more precision, we have so much information, again, like on our watches and on our phones, and we're always kind of looking to see, how is it going and how I'm doing. So I think that is where we may be going, is not being so focused on our own self-report, but our bodies may be telling us that we're at risk before we even could know that we're at risk, and that has a tremendous potential for intervention.
Some of this question was more to add to that too. I think from a clinical perspective, by intervening before the risk behavior happens, I think tends to be more productive than after someone's having. People often have had the effects of their drinking too much, right? But it's really not deterring them. So I think by getting that, before they actually drink, by looking at the markers, I think that a lot more leverage.
All right, well, thank you very much.